This year we celebrate 20 years of founding. We were founded by Father Angelo D'Agostino, who was a Jesuit priest and a medical doctor, back on the 8th of September 1992. At that time, we were reaching out to children who were totally abandoned because of their HIV status, left behind in hospital, on the side of the street, at a police station, but also rejected by extended family because of ignorance about HIV, fear and stigma. Currently we're caring for 115 young people, children and young and adolescents here in Nyumbani home. But right from the beginning we knew that we needed to reach out to the outside community, and in particular to children who were carrying the virus and living with some family in the resource-limited communities surrounding the city of Nairobi. So we started in 1998, and now we reach out to these children through 8 centres surrounding Nairobi city. Currently we're caring for approximately 3,100 children, all positive. Father D'Agostino also envisioned reaching out to the 2 left behind generations of the HIV pandemic, and that is grandparents who have lost their children and groups of children whose parents have died. Some of the grandparents who have been asked to care for their grandchildren are unable. Many are able, but some are unable because of destitution and age. So we invite grandparents who are caring for grandchildren to come into a village which we created from the ground, and we ask the grandparent to take into the family groups of children from child-headed households. So we blend the families. So a family in Nyumbani village, which is the name of the place where these people live, a family consists of a grandparent who is caring for approximately 10 children, only some of whom are biological grandchildren. So currently we have 91 families living in the village, 95 children, and of course 91 grandparents. And we have a primary school, a secondary school and a polytechnic there to cater for the needs of the children. We also of course have a medical clinic, and we have a police post, we have a community hall and a guest house. So it's like any village in the rural areas of Kenya, but of course it is a simulated village built from the ground. Only about 4% of the children in the village are carrying the virus. So currently we are caring for approximately 3,400 children who actually are infected with HIV. We are, as a priority, endeavouring to try and help mothers who are positive and are pregnant to have antenatal care where they can be put on antiretroviral medication, ideally from the 13th week of pregnancy, and that after birth the child gets the prophylaxis, and if the mother chooses to breastfeed the child, both the mother and the child stay on antiretroviral medication so as to prevent the transmission. So that is a priority with us, especially in our community-based care programme, where we do have contact with mothers who are pregnant and are also infected. When UNITAID made the fixed dose combination available, we were simply delighted. I talked to one girl who was on first line, and when the fixed dose combination came out, it suited her regimen. And she said, she's an adolescent actually, and I said to her, you know, how about taking your medicine when you're in school, boarding school? And she said, but I'm going to take one tablet a day, so no, in the morning and the evening, so no problem. I think I told you that story, right? So, but I think Matron can talk more to that, what it means for the children to have only to take just one tablet morning and evening.
When the fixed dose combination came, our children were using so many drugs, so many tablets at a time, so it was very easy, and children were, the pill burden is reduced, and the compliance also is, now it is good, because if they don't have to forget the medicines, whether they have taken all 3 or 4, the number. Then also for the outsiders, the cost is reduced. So this is a good idea, and also if you get so much more medicines in fixed dose combinations, it will be great for the people, especially the children who are taking the medicines, so many of them at a time, syrup form, tablet form.
Since 2005, we have been receiving the drugs through the President's Emergency Fund for AIDS Relief, through MSH, and now through Pharma. That's the pharmaceutical company that provides the drugs. Our children started to go on ART from 2000. In those days, Father D'Agostino was lobbying for sponsors, and he also would get sometimes donations, like we got ACT from Brazil. So when the PEPFAR program started, our children were on various regimens, which didn't always fit in with what PEPFAR was providing. So in the beginning, we had to get them through the Clinton Foundation, wasn't it? The pediatric doses. And even now, some of the regimens on which our children are not what we call standard, but we still get those drugs from PEPFAR for first and second line. We don't get third line drugs from PEPFAR, but we've got access to compassionate use for 2 of the components of the third line regimen, and we have to purchase the other. Children are still being abandoned. Mixture maybe of reasons why they're being abandoned, because there's more awareness of HIV now, and also, like for example, in the early days, the mother believed that the child was going to die, and so it's better to abandon the child, have the child picked up by somebody and brought to be cared for. Now, it's generally known that, first of all, that the child isn't necessarily positive, because the mother is pregnant, is HIV positive, but also that there are drugs. So there is more awareness about and knowledge about HIV. But then there's some others who are desperate, and they abandon the child. We have centres in all these resource-limited communities surrounding the city of Nairobi, which we pejoratively call slums. We have centres to which the parents or the caregivers bring the child, and then we do give the same holistic care that we give to the children here, which of course includes ART when the child needs to go on ART, and then we give them a month's supply, and then we train the caregiver about the importance of the adherence to the medicines, and the time, you know, every 12 hours.
Mm-hmm.
But when you're living in those conditions, time often isn't your priority. Your priority is looking for food for the family, and you might get a job and you're back late, you know, so there are all sorts of problems. But still, our children are living, and they're healthy now. So we try as far as possible, as the children get a little older, to help them be aware of the importance of taking their medicine, so that the adherence is maintained. Pride of the country to be able to serve its citizens. But at the moment in Africa, we haven't got the resources developed yet. We will get them developed. We know we will. But we're not there yet. So, fair enough, we would want to have country ownership and self-sustainability. And we aim towards it. But we can't be pushed there. You know, we've got to be helped to develop the economic resources. But from the point of view of healthcare in our world, there's sufficient funds in the world to ensure that every human person in our world gets basic healthcare. And care and treatment of HIV is basic healthcare. I believe the drugs should be free, just like TB drugs are free. I mean, that's the way it should be. Like, for example, some of the pharmaceutical companies have been invited to join the medicine patent pool, which UNITAID started. I believe that they have to be, I don't know whether it's shamed or whatever, to join the medicine patent pool, so that they either reduce their prices for the developing world, or else they allow the generics to be manufactured.
In Kenya right now,
Yeah.
do you think anyone who needs ARVs can get them?
No, no.
Even
We
though...
talked about 600,000 on ARVs, but there's still a number still that need to access. Now, some of the reasons is accessibility to healthcare, and also knowledge of one's status.
Yeah.
Because in some of the rural areas of this country, a person may be positive but is not aware. You follow? That particularly would apply, I think, to women whose husbands migrate to the cities for work, and then when they come back, if they're infected, they can pass the virus to the women. Our first boy, who came in 1992, he trained in flight dispatch. Sadly, he didn't manage to get a job in flight dispatch, so he's decided to do social work training. But currently he's working with us here in our stores. So he came in 92.
Right.
So now he's 22. Yeah, 23.
He lives
now
outside.
23. Yeah. He lives outside in his own accommodation.
Right.
We have a boy doing law, second year law, he's just finished. We have several who are outside in their own accommodation and have a job. So our eldest is 29 this year.
Right.
He's got a job and living in his own accommodation.
Not on ARVs.
No, they're not on ARVs.
No.
He's one of those exceptional cases.
Well, he doesn't need to be.
It doesn't need to be. There's something in his DNA
Okay, one of
that
those.
is preventing the replication of the virus, but he still has the virus.